Good morning. A little bit of fun. And the really smart person here is Ed Ellerbeck. Ed is the chair of population health, and he joins us this morning. We're going to talk about modeling and what we expect as things reopen and where we are in Kansas and really across the country. But also, we do want to say that we apologize that Lee Norman was not able to make it. He's flying around Kansas today in some sort of a Stratotanker refueling plane in recognition of healthcare workers. I don't know exactly why that means he couldn't be on the show. I think that meant he probably had a better offer. Maybe the view is great up high. And he promises a rain check, though, and we'll take him up on that soon enough. So, Dana, how are we looking today? What's going on out there?
We're good. Still cautiously optimistic. We have 16 in-house today. 7 of those patients are in the ICU. Again, we've continued to have discharges as well as new admissions. But certainly, I think if we can keep our numbers lower and lower, that's going to be the best thing for everyone.
All right, David, here we go. Let's start. Okay, so just for our listening audience, just so you know, David is the eternal pessimist, and I'm the eternal optimist. We
realist,
play this great
not
role.
pessimist.
We
realist.
play this great role back and forth. No, the realist, the pragmatist is that element. That's how that's going to fit. Okay, so talk to us. What are your thoughts today? How are things looking?
Well, I think I'd agree with Dana, sort of across the board, cautiously optimistic. We've seen some signs in the last week or so that even at the county level that we're maybe beginning to see a decrease in new cases. And that I think is a good thing. Then that means less people in the hospital as well. And so the added benefit there is we have more time, we get more data, and we have a better understanding of what's actually happening. So it's not so much based on models of what might happen, which was one of our limitations early. How might this disease work? And now we kind of know what is happening. And so that provides us a little bit clearer lens into what may happen in the future.
And we've not had the big surge that some people predicted. Talk to us a little bit about why you think that's true and what the future holds.
Well, I think that we really had a good success with the social distancing program. I think we really did bend the curve effectively.
And what do you think's coming as society reopens? You've probably been out a little bit. Surely you've been out and about and looked and seen what people are doing and what they're not doing.
Well, I do live close to Luce Park, and I do have to admit that it's very crowded there. And when I do my runs, I try to keep 15 feet instead of the 6 feet, worried about that side stream infection potential. I will tell you, this is a very unusual situation for me because I think I'm going to be more of the pessimist to David's optimistic approach.
David just said that because I'm here, Ed. Otherwise, it would have been worse.
Realist. I keep coming back to realist.
Well, the issue here that I wanted to bring up is the idea that our infection rate is down quite a bit, and in fact. But if you go back into history, we put the stay-at-home orders in Kansas on March 28th, right? And at that point in time, I think Johnson County had 16 new cases. The state as a whole had 59 new cases. Right now, we're averaging 150 cases per day in Kansas. Now, most of those are outside of the metro area, and we're at a lower rate in the metro area. I think Johnson County now is around 6 cases per day, and Wyandotte County probably somewhat close to that. So in the metro area, we've actually done a nice job of contracting things, but we're back to where we were at the start of this. And so as we loosen things up, we really could get see some spikes a couple months down the road.
And David, that's been the concern all along, are these kind of waves of surges. What are your thoughts around that?
Yeah, I agree with Ed that the sort of lower rates that we're seeing now in this back to baseline level is really a result of what we did 2 or 3 or even 4 weeks ago, meaning the impact of social distancing, the changes that happened quite some time in the past. We now see the benefit in new infections. And so as we open, I think we all expect some degree of sort of rise in the number of new cases per day. And I think I have the same sort of concerns.
Yeah, actually, I have those same concerns. So God forbid we're on the same page on this. This is a market
Something doesn't feel right here.
History. Dana, what are your thoughts about it? And also, talk to us a little bit about the role of hydroxychloroquine, which popped back out yesterday as we learned that President Trump was taking hydroxychloroquine on a regular basis.
Yeah, knowing about this virus and the clinical efficiency with which it spreads, I think we have to assume that there will be more cases. It's unfortunate. We don't want that for anyone, but as people open up, there's more people who are susceptible. Certainly, I think there'll be more cases.
Should we be taking hydroxychloroquine?
That's a very good question. So the best evidence that we have is based on some trials. There are trials which show maybe there is benefit to hydroxychloroquine. However, the best evidence, the best trials, the best publications that we have show that there's no benefit on mortality or improvement. And in fact, there could be some detrimental effects, such as side effects, such as heart arrhythmias and heart attacks. So again, I think the best published studies we have would show no benefit or even possibly detrimental effect. But that's for people who have the disease. Now, what about people who are taking it prophylactically or in an effort to protect them if they do get infected with the disease? We still don't know the answer to that question. We know that there are trials going on now, mostly involving healthcare workers, for people to take it prophylactically in case they are exposed or in case they do have early infection, things of that nature. So those trials are ongoing, and hopefully we will start getting some of the results from one of them soon to say, will this prophylactically prevent me from getting the disease if I come into contact with the virus? So that's a very big question that we're still waiting to answer.
So the healthcare workers trial here, the HERO study, is ongoing. I know they've had some recruitment. We need to get those answers out before we can really say a lot about hydroxychloroquine as a preventive measure then.
Yep, and there was also a second trial done up at University of Minnesota. One of our physicians here was also trying to recruit for that as well. So again, there are a couple trials. Hopefully we'll get some of that data soon to show us, will it help protect against infection?
Ed, what do you think is going to happen to some of our rural areas around Kansas? Some of the counties haven't really seen many cases, or some not at all, I think. And yet we're still very concerned as people begin to open back up society, start traveling more. What do you think is in store?
Well, I think we've actually seen some of our biggest outbreaks in those rural communities. And I wanted to harken back to what a study that Dana was, I think, describing yesterday, which is the choir practice study, where out of one infected choir member, out of 61 people, I think the attack rate was about 87%, including 3 people who got hospitalized and 2 people who died. And so it goes back to these old adages that I learned as I was growing up on the farm. It was like, one bad apple spoils the whole bunch, or the chain is only as strong as its weakest link. So it only takes one person within the community to be infected in the right situation to get some fairly substantial outbreaks. And so I think our rural communities are susceptible to having repeated outbreaks as we move along.
So Ed, where did you grow up?
Out in west of St. Louis, in a little place called Forestville. Grew up on a farm there.
Yep, there you go. So as you look across Kansas, there have been some pretty significant hotspots in some of the meatpacking industry and some of those areas. How is that going?
Well, it's a substantial problem. And what we saw is that in these industrial situations, and there's a lot of industry in rural Kansas, and so you get 1 or 2 infected workers within one of those communities, and it can be a hotbed for future spread. What we haven't actually seen yet, and which still could come, is those workers now may be living with other people who actually now work in the nursing homes. And so we're very concerned about secondary subsequent spread within other segments of the community in our rural areas.
The rate of hospitalization in some of those areas seems different, and has the disease changed or something? Because it doesn't feel like we're seeing the wave of hospitalization we would have expected from some of those areas.
Yeah, it's a great question, because when we look at some counties, we see hospitalization rates of 2 or 3%, which of infected, which is maybe lower than some of the early looks in other areas across the United States and really across the world. I think there are a couple of things at play there. I think there are maybe a different population that are being infected. For example, we know in Wyandotte County when there were larger clusters in nursing homes of patients with coexisting disease and of an older age, there was a higher hospitalization rate. And now that the majority of the new infections in Wyandotte County are in younger or not in clusters of nursing homes, how about that? There's a slightly different hospitalization rate. So maybe different people getting infected than early on, or at least the clusters are in different places and then a different demographic of the patient population. And I think maybe the second thing is we thought that hospitalizations really started 7 or 10 days after infection. And now that we know a little bit more about the number of days of asymptomatic infection and how the course of this disease actually plays out, maybe it's a little bit longer. Maybe it's 12 or 13 or 14 days. And so some of those clusters are just past that point now, and we might see an uptick. We just don't know yet. But each county, because of the transmission dynamics that vary from county to county, each county is behaving very differently.
Yeah, it is kind of remarkable how that's really been true. Well, let's turn to our media and see if anybody from the media colleagues out in our audience has any questions, either for in general or for some of our modeling colleagues.
Hi, this is Melissa. Go ahead.
Melissa, this is Matt Fleener from KNBC. You talk about rate of hospitalizations. What's the best way for the public to track that?
All right, Ed, what do you think, or David? Rate of hospitalizations. Can the public really track that right now? It's hard.
Mm-hmm. Yeah, there are some Tableau websites that will actually show. Some of our county health departments are putting those up. I think the state has a Tableau website that they actually use. You can also look at the COVID tracking project and look at day-to-day changes within that.
Tableau website, Ed.
Well, I mean, Tableau, if you just do coronavirus and Tableau, just because a lot of them are actually using Tableau as their visualization platform, you can do Google coronavirus or COVID Tableau and whatever the areas that you're looking at. But you can also pull it up with the COVID tracking project as well.
David, other thoughts?
Yeah, I think Ed's right. Those sites are the places that we look to see. Unfortunately, there's not always a standard definition of what hospitalization means, meaning some people are including observation or outpatient stays for one-night stays and some people are not. Some places report every day, some places report every couple of days, and so it is challenging, I think, to get a great sense, but I think all those places are good places to get a rough idea of what's happening.
Okay, great. There's another question out there from our media.
Hey, this is Melissa with Channel 41. I know you hit on hotspots a little bit in the state, so this is probably for either David or Ed. What can you tell me about the Grossman Center in Leavenworth County? They went from 42 to 67 cases in just a few days, and we're hearing from a lot of concerned residents inside there. So what, if anything, can you tell me about what's happening there at the Grossman Center?
When do you know about that? That's not something I'm as familiar with, so.
Yeah, I don't have a lot of details. You know, we tend to get some information about transmission dynamics from the health department when they understand what's been happening from being on the ground. And I don't have a great Leavenworth County Health Department contact. I don't know, Ed, if you have any other insight.
I don't have insights into that specific outbreak. I would say that there has been quite a bit of variability in the testing strategies within some of our industries as to is everybody being tested across the board, or all the contacts being tested, or only symptomatic individuals being tested?
So we're going to look into your question, and we'll try and get back with you a little later today. Both David and Dana can help with that a little, and Ed as well. But we'll try and reach you here in a few hours because we'll go learn a little bit more ourselves.
I know how to find Melissa.
Yeah. Okay. Next question. Any other media questions?
Correct me because I may be a little bit off on this, but I think we're still running around a 20% positivity rate across the board. And that suggests that we're really just still testing the symptomatic individuals or particularly high-risk individuals. And a little bit of symptomatic transmission, and we need to be able to identify people who are asymptomatic potential spreaders and get them isolated.
Ed, how would you go about doing that if you could design the program today? Because we do think there are unused tests being done now on a daily basis here and other places that are available. How would we go about designing that system, especially here in the Kansas City metro area, let's say?
Well, I think we're going to have to move beyond a little bit where the CDC is at. They're still staggering the testing criteria and focusing on the symptomatic individuals, and it still is a scarcity policy that they have in place. I think that we actually do need to refer asymptomatic individuals for testing, and then where we actually do see industrial outbreaks or particular high-risk situations like we have in some of our nursing homes, we need to get those asymptomatic contacts tested quickly.
David, other thoughts with that?
Yeah, so I would agree. I think, Ed, if we look at the statewide positivity rate or a large population positivity rate, it's still pretty high. Definitely 15, 16, 20%.
And just for our listening audience, let's talk a little bit about what it means to be high. Is it really high because a lot of people have been infected, or is it high because we're testing patients we think have a good chance of having the disease?
Yeah, so both. I think both are true. No matter what, the harder you look, the more you'll find. And so the more we test, the more likely we are to find those asymptomatic individuals. But if there has been a significant shift in the testing policy, and I'll give an example, I think it's really important to look at maybe Wyandotte or Johnson County, for example, and understand what the decreasing positivity rate means in each of those counties. So, we're doing a lot of tests every day on patients. We're screening patients as they're admitted to the hospital before they start chemotherapy or in preparation for surgery. We're doing a lot of tests every day, a lot of tests.
That is really a screening test of a more of an asymptomatic population, right, although they are counting healthcare.
Correct. And so as we look at the positivity rate for tests done in our lab, it has decreased over the past few weeks because we're testing so many more asymptomatic patients that we don't expect a positive result. And that has changed the positivity rate in both counties because patients coming to our hospital live in those two counties. And so, yes, there's probably a decreased incidence of disease, right? The number of new infections in each county, but we're also testing a little bit differently here. And so looking at a positivity rate this week compared to a month ago in those same counties is number of people being tested in those counties is very small, as is the percentage. I mean, think about the concept that even in the highest testing rate counties, we still have tested maybe 2 or 2.5% of the population. We don't have a great sense of what is actually happening because we are limiting testing, as Ed describes.
Dana, David, Ed.
Yeah.
All right. Make a guess. What do you think is that in the population, what percent of our population has been infected with SARS-CoV-2 so far?
Only a known cases of, I think, 8,500. I may be a little bit off on the numbers, but that just shows you that the testing really matters. And when you test only certain people, that's what you're going to get. Only certain populations, that's what you're going to get. But the actual prevalence of the disease is probably way beyond that. So, that's going to be really hard to say. I think we certainly want to be able to test as many people as possible to really understand the infection dynamics going on in our particular area at any one time.
Yeah. Ed, any other thoughts about that? How many people do you think are infected? This is your population health question for the day.
Yeah, well, if you flip it around, I'd talk about how many are still susceptible. So my hunch is it's above 95%. It's probably closer to 98% are still susceptible in our area.
And that's still the fear when we open up our society. So talk to us a little bit. I want to return to that question about per 100,000, and then I want to talk about the effect of population density. So let's first of all, why do we standardize statistics per 100,000? Ed?
Well, I think that really is so we can compare apples to oranges and look at the overall rate of spread within a community.
I think
it's reasonable to do the adjustment, but again, we really do need it only takes one case again to get an outbreak going, and so I wouldn't be totally reassured by low rates of population adjusted numbers.
I'm actually not, and I'd even say I'm scared by what I see going on out in the community a little bit, because I think it is still out there, significantly out there, and 2 weeks from now, by June 1st, we'll get a lot better picture than we have today of what reopenings meant. And I harken back to the example we talked about yesterday of things that are going on in some of our restaurants or other parks or places like that where folks are not social distancing. It's like life is back to normal. It ain't normal, and I get a little nervous about that.
And I think it's easy, this population or a population adjusted conversation. I think it's easy to say, wow, the numbers in Kansas don't compare to, say, the numbers in Missouri. But as of yesterday, for total cases, Kansas was 23rd out of 50 states and the District of Columbia, with lower being better, right? So the 23rd highest per capita rate of infection. And I think if you just look again at total infections, it seems like, oh, we're pretty low on the list. But that's one of the reasons that we do correct or use a per capita number to compare.
You know, two questions I want to throw out there, and we return to our media. First is the impact of density, because I think one of the things we read about now is that the ability to transmit and communicate, or to get the disease, and maybe the severity of the disease, can be related to both the amount and the duration of an exposure. So Dana, talk to us a little bit about that, and then I want to flip that over to what's been happening in Wyandotte County and some of the meat packing plants, and just talk for a minute about some of the racial disparities we see, and whether or not those things about duration and amount of exposure are related to living conditions. Dana.
Yeah, absolutely. I mean, duration is a large umbrella, and what falls under that umbrella? So there are proximity. So we were saying, you know, if you can maintain a further distance apart from each other, so not a close proximity, but also into that is also time. So, you know, a hug is 1 second or less. But if you are continuing to have conversations and talk with people and you're at a closer proximity, obviously your exposure is going to be greater just because you are close to that other person, but also the time that you're with that person is very important for having a higher risk exposure.
Yeah, you know, the choir study that was mentioned yesterday and hinted at again today.
And it was a 2-hour choir study, and they broke off into separate groups, and then they were densely, and then they came back together again.
The chairs, the map that the CDC kind of placed, you know, shows those chairs were 20 to 30 inches apart, and for a couple of hours. And so you start, that's a great example of this thought that you multiply the duration, the amount of time, by the degree of distancing. We're really close, and then you see how this actually happens. And then the airflow
in the room, and the ventilation, and where they are, all those things make a difference. So Ed, when we think about Wyandotte County, where there's been a more significant outbreak, talk to us a little bit. I mean, you've done work in racial disparities and things of that nature. Talk to us a little bit about some of the
who have to take mass transit together, people who are working in environments such as an industry or a meatpacking processing plant where they are in much closer contact with each other. And those individuals in those living and working in those situations or using that type of transport are much more likely to be less wealthy and to be from some of our underrepresented minority communities. So they are bearing the brunt of this crisis.
As I have in other areas around the country.
Nation study, or well, I won't say study, descriptions of disease transmission there, right? The highest per capita rate of disease right now in the United States. And one of the key features, a nation that's been on lockdown, one of the key features that they believe related to transmission there was the multi-generational family units that Ed described. Right, a very, very, very low population density, yes. A really high rate. And so I think all of those things are important to understand, that living with someone definitely is different from living in an apartment building where you are separated.
Yeah.
Yeah, I think we have, you know, they have, what, 50% more per capita compared to New York, which is a huge number, you know, when you think about the small, I think it was 175,000 or so in their Navajo Nation. But to go back to that too, it's unfortunate too, because those, the groups that we're talking about with the biggest health disparities are also the groups that are most important to us. Our first line workers, our supply chain drivers, people that we count on every day. And so we really have to keep those groups with those disparities healthy so we can all continue to function as a society, because they are extremely important to us.
Indeed. So turning back to our media to see if there are other questions. And Matt, did we address yours?
So I have a question. I think this is an opportunity to try and define asymptomatic. The person writes, I am someone who works closely with a couple of COVID positive coworkers. Twice I have tested negative. Does that mean I'm asymptomatic?
The infection, you just, at this point in time, don't have any symptoms.
Would they test positive then?
You should test positive at that point, yep.
So this person just hasn't
is
caught it.
probably negative and has
You know,
not
you haven't
been
caught it,
infected.
and you haven't caught it, so you're asymptomatic, or
Right.
you've caught it and you're asymptomatic. Either of those things could be true.
Right.
The test
Yep,
is
yep.
negative
But I
both
think
times.
and
Well, the test is
being
negative is a good sign. Related to this a little bit is about as people go back to work, if their offices or workspaces are 6 feet apart, do you still need to wear a mask? What do you think? David?
After a while.
Well, I'm going to actually use Ed's example of running, saying, right, 6 feet is what's recommended, but I keep 15. I think, there's no, well, how about this? Droplets and virus don't necessarily follow our mental constructs for rules, that at 6 feet, the droplets are going to magically drop to the ground in every circumstance, or that those droplets won't contain virus to be infectious. So, I think in general, my answer when people ask questions like that, 6 feet is better than 3, 8 feet is better than 6, a mask and 6 feet is better than 6 feet with no mask. So it's all about the risk and the disease transmission in your environment, and
And how much risk you're willing to
take,
entertain,
right.
and how your overall health is. Because if your health isn't great, or you're older, if you have high blood pressure, if you have diabetes, if you're overweight, then you better take more precautions than if not.
If if the question is a mask required? Well, probably not. There's no requirement that you must wear a mask to keep from getting the
Right.
disease. But the more you do, the farther apart you are wearing a mask, both people involved in a conversation wearing a mask, the lower your risk of transmission.
And so here we are in the studio this morning. You all are more than 6 feet apart. We do measure this mouth to mouth and make sure. I encourage people to talk forward and not at me here in the center. But we've made the decision here. We're not wearing masks now. As soon as we're done, we put the mask
we
back
took
on.
it right off right before. Yeah.
And part of it is folks have a hard time understanding me at baseline. If you put a mask on me, Mumble City becomes Mumble Jungle.
And some of
that's
our
the problem.
tech guys can then put in any words they want when people can't read our lips. So we're protecting against Logan and Cliff.
All right, thanks Logan and Cliff, who just gave us the thumbs up sign. They've been discovered. All right, so let's talk for a moment about the serological test. This comes up every single day. What do we think about the serology test? When are we going to have them here, David?
Great.
I'm blaming you. You've been most in contact with
I've been saying
Yes.
in weeks, not months, for a couple of weeks now.
You've been saying weeks.
I hope that we're
For
at
weeks.
days. There's I think a growing evidence that there are some really good serological tests that are commercially available now, or will be available. They've been approved, but will be available to reference labs or hospital labs here in the very near future. So I remain optimistic that we'll have a better sense of both when they'll be available and then how we use them, because that becomes, in my mind, the next important question. Probably not so much at this point for diagnosis. I don't know, Dana can disagree with me, but more for understanding the total prevalence of the disease, and then the number remaining susceptible in the community. It gives us a better sense of how we can reopen, public policy, those things.
Yeah, absolutely. I agree. We can't use it for acute diagnosis. We have to understand that. This is an antibody test. You typically won't develop any IgM antibodies till at the beginning, probably about 5 days into the infection. Those are short-lived antibodies. You probably won't develop IgG antibodies. Most people develop them at 11 days. By 14 days after infection, most people have IgG, and those are what we are talking about will hopefully confer long-term immunity. I don't think there's any role for acute diagnosis, but I had a friend contact me yesterday because he thought he had COVID toes. He didn't have any symptoms of illness, no cough, no fever, no shortness of breath that we talked about, no other loss of smell, but a couple weeks ago developed these lesions on his toe and thought that he had COVID toes. Now, I think for that person, as we are 3 or 4 weeks out, that may be reasonable to get an IgG test to see, did I actually have COVID, or is this just something different? So there are those very small instances where it may be helpful, but for acute diagnosis of infection and worrying about infecting other people, things of that nature, the serology test probably will not be helpful.
And can you define serology? Have people asking, what does that
So
mean?
serology is just a bigger word for antibodies So IgG antibodies, that will be something else you'll hear. Most of the tests are going to be looking for IgG antibodies. We hope that if you have IgG antibodies, it will confer some sort of immunity to reinfection and some sort of protection, but we don't know that for sure. We're hoping that these antibodies are neutralizing, meaning they will stop the virus from further infection and damage in your body.
Ed, when you,
Person asking.
I was going to go to Ed, sorry.
Oh, all right, go
hey,
ahead.
Ed, when you think about some of the questions you get, I know, around workplace environments, et cetera, what are some of the advices you would give to individuals about how they can help make a workplace environment as safe as possible?
Well, I think the social distancing that you described, wearing masks, remember you're wearing masks to protect the people around you. What worries me is sort of this toxic masculinity where people view that they're the tough guy and they don't want to wear a mask and don't appreciate that they're wearing that mask to protect the other people around them. Harkening back to the previous question related to the person who was around infected coworkers and gotten herself tested twice and was turned out to be negative, I just wanted to congratulate that person. They shouldn't be embarrassed about having tested negative and being overly concerned. We just really need a lot more people who have been exposed to push and get tested even though they're asymptomatic.
And Ed, when you think about air conditioning in HVAC in buildings, any thoughts around that?
That gets out of my technical area of expertise, so I'll beg off on that.
Yeah, I think that for the most part, again, this is not airborne like measles, which is one of the most contagious viruses on the planet. That is airborne. Tuberculosis is airborne. We still believe that this is droplet precautions or droplet spread. So really, I think air conditioning, HVAC systems really don't pose too much of a risk based on and David can correct me, the cruise ship, they really pretty much, I think, ruled out air conditioning or ventilation system in that small enclosed area. So, certainly if you are by a vent and it's blowing by you and the stream from the air is going by you, it can obviously carry the droplets farther. But as far as real airborne, as we think about with measles or tuberculosis, that is really not significant with this virus.
Yeah, I think if this had been truly airborne, we would have seen even a lot more people getting sick. And I think I actually am reassured as a pulmonologist that really this is not truly an airborne. And the difference is airborne means it can float in the air and be carried in the air and be carried by the wind. That's one of the struggles with tuberculosis, along with droplets. Still, droplets are still a big deal, even with TB. But we think that the droplets that you cough out, which tend to be heavier, and hence the 6-foot rule, are probably the way the coronavirus is passed from others. And the reason 6 foot is that's the standard distance of how far people can breathe out or cough out. If you think about it, when you go outside in cold weather and you can see your breath, how far does your breath really go? It doesn't travel forever. And the wind begins to break it up really rapidly, which is also why you're better off outside than inside, where the stuff can sit there because there's not as many air currents. You go outside and it starts to be dispersed. And once it's dispersed, we think that you're not as likely to be infected, in part because there's not as much density of the infected particles that come your way as there is in an inside environment, and there's not as much ventilation.
So I got one scientific question and then a round robin with like 3 little very common questions. So the first one is, are the doctors familiar with, and I'll probably say this wrong, La Institute study with T cells? La Jolla. There you go.
Yeah, La Jolla.
La Jolla.
So that means, Dana, you're familiar with it.
And what does that mean for vaccine?
I'm not sure what they're talking about. There was a study recently looking at T cells. So we understand that your immunity is based, in simple terms, antibodies or cellular immunity. So we know that T cells are very important in our immunity. The HIV infects T helper cells. So T helper cells and cytotoxic T cells all are part of our immunity to help protect us against infections, especially viral infections. I think that there was a recent study that showed that maybe some of the T helper cells had cross-reactivity or had some activity against SARS-CoV-2, even though patients or people had never been exposed to SARS-CoV-2. What they associated that with was just some mild cross-reactivity with the other common coronaviruses that we know of, the 4 coronaviruses that cause common cough and cold symptoms. I don't know that that's really significant in the immunity, but certainly in the lab setting, they did show that there was some mild cross-reactivity of those T cells to the SARS-CoV-2.
You know, we had good news last week with Senator Moran when we spoke about Dr. Francis Collins, head of NIH, his announcement last week with our board meeting that he was hopeful that we would have maybe 2 different vaccinations available in October.
Yeah.
That's game changing as far as what it means for SARS-CoV-2 and our ability as a society to respond, and then thinking selfishly reopening of sporting events, including Chiefs games, get a whole lot safer once there's a vaccination available. Time for one more quick question because I want to get back to our guests too.
Right. These are
real
media
quick.
questions, and
Yep.
they're all kind of in public health. So 3 real quick.
Okay.
One of them, first one is it okay to get a facial?
All right, facial, massage, haircut, those are all right there together. We'll start with the facial, Dana. It's hard.
I was going to throw this one to David, but
Nice try.
you know, again, we have continued to talk about mitigating risk, minimizing risk. We know that society needs to open up. We know we need haircuts. People have to get things done. You have to be individually vigilant about minimizing your risks. Things to do is don't go do those things if you're ill. Make sure that the person performing those is not ill. Hopefully they are honest. Don't go out and really unless you need to. Make sure that you're using hand hygiene, going right before maybe you go into the shop. Do it right when you're coming out of the shop. And if you have a hand sanitizer or a spray bottle of alcohol, use that once you get into your car. Wear a mask, especially if you're getting a facial or getting your haircut. That is a close proximity for quite some time. You know, for men, it's probably 20 to 25 minutes for a haircut. For women, it's certainly a lot longer. And so that goes back to the close proximity and the exposure time. So that is very high risk. If you can do all of those things, you won't eliminate the risk, but you'll certainly minimize it as much as possible.
Yeah.
So massage was the second, so we won't go there.
Yeah,
but
same.
water aerobics, they said the gym, all the other parts are not going to be available,
So
and
it's
they've
water
done that.
aerobics. So let's take on water aerobics. The other,
Risk. It's hard to wear a mask when you're exercising, and if you're in that environment, the mask is probably going to be wet and rendered useless anyways.
yeah. So as we wrap up today, a reminder about tomorrow, we have a cancer and COVID session. We always have a lot of questions about cancer. So with us tomorrow is Roy Jensen. He is the head of our cancer center in the NCI cancer program here at the University of Kansas Health System and Medical Center in this case. And so he'll be with us to join and talking a little bit.
Kids staying up to date. I just wanted to congratulate your team on doing an incredible job of making the health system a safe place to work and a safe place for our patients to come. And we need to actually get our kids in for their regular routine checkups and their immunizations and regular health maintenance.
Thank you. You don't want to get sick, afraid of becoming sick. And that's an important message. David.
Yeah, I think my general message is, you know, thanks to everyone for all of the hard work around social distancing and bending the curve, because it has changed the environment and allowed people to get back to work or come back to the hospital to seek care, or to go, as Ed mentioned, and get that preventative health care that's important. I think it cannot go unsaid that is due primarily to the behavior changes and sacrifices that our community made, and that's been really important. So thank you for that, and keep up the good work. Don't let it all go to waste now.
Dana?
Yeah, I would like to echo what Ed and David said. You know, we haven't seen historically a lot of co-infections, meaning COVID and another infection, and kids have mostly been spared from this disease. But I think it would be certainly tragic if they aren't getting their vaccines and then they get COVID for some reason, but also get these other preventable infections on top of that. Measles, mumps, whooping cough. They would probably not be spared from critical disease. So I think it's very important to continue regular preventive maintenance and getting the vaccinations, whether you're an adult or a child, to protect you from these other things that we can protect you from.
Yeah, remember, you're not only protecting yourself, you're protecting for everyone you care about. Just think about it like this: June, July, August, September, October. 5 months. 5 months of continuing to change your life so you can live the rest of your life. And so can your family and friends. Vaccination's not that far away. Just remember, there's still no place like home.